Welcome everyone to MedCity News' Invest Conference, where we discuss important shifts in healthcare and highlight the innovation that's driving that transformation. My name is Arundhati Parmar, and I'm the editor-in-chief of MedCity News. First of all, I wanted to extend a virtual hug to everyone that's attending today. Whether you were personally infected by the SARS-CoV-2 virus and recovered from it, or you never fell victim to it, I think it's safe to say that all of us are survivors. Survivors of the deep sadness that fills us when we think about the grim death toll of our fellow Americans, our grandparents, our parents, our siblings, our friends, and our neighbors. It's a deep, deep pain. But we are also survivors of perhaps losing a job, survivors of the deep disruption in our lives. Not surprisingly, this past 12 months has also filled us with a sense of purpose as we reflect on the inequities that are plaguing our nation today. Can technology help that? Can it alleviate some of the inequities? Can it humanize the relation between physician and patient? These are the questions that I hope our panel will be able to address today. So let me go ahead and start introducing our panel. Our moderator today is Christina Farr. She's principal of OMERS Ventures. She's a health tech investor and based in the Bay Area. OMERS Ventures is part of the private equity family of OMERS, the Canadian pension fund, Ontario Municipal Employees Retirement System. Prior to that, Chrissy was a journalist at CNBC. This is probably one of the most modest bios that I have seen as I have sort of assembled the slides for our conference. I think it's safe to say that Chrissy has really made not only a name for herself in covering this conjunction of health and technology. I think she has educated the wider audience that may not be as into healthcare as we are about the changes that are transforming our healthcare system. So welcome to you, Chrissy. Then we have Dr. Toyin Ajayi. Dr. Ajayi, board certified in family medicine, is co-founder and chief health officer of Cityblock Health, the first tech-driven provider for communities with complex health and social needs. Prior to Cityblock, Dr. Ajayi served as Chief Medical Officer of Commonwealth Care Alliance, a nationally renowned integrated health plan and care delivery system for individuals eligible for both Medicare and Medicaid. In this role, she led clinical operations, spearheaded care delivery innovations, and oversaw multidisciplinary teams of clinicians, community health workers, and administrators. Dr. Ajayi received her undergraduate degree from Stanford University, an MPhil from the University of Cambridge, and her medical degree with distinction in clinical practice from King's College London School of Medicine. She completed her residency training at Boston Medical Center and continues to practice primary care focused on patients with chronic, complex, and end-of-life needs. Welcome to you, Dr. Ajayi. Dr. Ami Bhatt is the director of the Adult Congenital Heart Disease Program and the director of Outpatient Cardiology at the Massachusetts General Hospital. She is an active clinical cardiologist, investigator, and educator. She graduated from Harvard College, obtained her doctoral degree from Yale School of Medicine, and trained at Mass General Hospital, Children's Hospital of Boston, and Brigham and Women's Hospital in internal medicine, pediatrics, adult cardiology, and adult congenital heart disease. Dr. Bhatt was nationally recognized as an educator by the American College of Cardiology in 2015 and by the American Heart Association in 2016 for ACHD program building and design efforts. She innovates at the MGH Corrigan Minahan Heart Center in the domains of telemedicine for ACHD patient visits, provider consultation, multimodality teleconferences, and adoption of mobile health technologies for caregivers and patients. Welcome to you, Dr. Bhatt. And then we have Harsh Vathsangam. He's the CEO of Moving Analytics and leads a company that provides virtual cardiac rehab and comprehensive cardiovascular disease management programs to support cardiologists and health plans in improving the health outcomes, quality, and cost of care for their members. Developed in partnership with Stanford University, Moving Analytics programs are based on more than 30 years of published research involving over 70,000 patients. The company's flagship product, Move-In Virtual Cardiac Rehab, which targets patients after an acute coronary event, such as heart attack or heart surgery, has been adopted at marquee organizations like Kaiser Permanente, Highmark Health Plan, Allegheny Health Network, and the Veterans Affairs. Harsh received his PhD from the University of Southern California. He holds an undergraduate degree from the Indian Institute of Technology in Chennai. Welcome to you, Harsh. And with that, I wanted to turn over the discussion to Chrissy and the panel. The last 15 minutes will be reserved for Q&A, so you can send questions through the chat, but please wait for Chrissy to signal to you that she's ready to take questions. Welcome, Chrissy, and all the panel.
Thank you so much for that kind introduction, and I'm really excited for the topic today. I think it's a really good one, and I got chills hearing you talk about this COVID situation that we've all been through, and hopefully there's a light at the end of the tunnel now, and those on this panel are getting vaccinated, and I recently got my first vaccination, so it's I'm just thrilled about that and starting to kind of feel that life can resume back to normal. But in this period, we've seen massive technology adoption in areas like telemedicine, just on an unprecedented scale. I've heard from various folks that what would normally have taken 5 years all happened in the space of a mere few months. So the panel, I think today we're going to be exploring whether this trend continues or whether we kind of snap back to what we saw prior to the pandemic and the status quo. So I'm going to kind of start with that question and ask all of the panelists, what has been your experience with technology during this pandemic? We've got a number of doctors on this conversation. Did you start seeing patients virtually, and how do you feel about it now that we're just starting to resume in-person visits? And we'll start with Dr. Bhatt.
Well, thank you for having me, and Arundhati, thanks for the introduction. So I think when we think about what has happened during COVID, we can take a step back and just think about telemedicine before. There was most certainly telemedicine before COVID, yet the uptake for the kind of broad average American citizen was actually not that great. And it's interesting because when COVID happened, we noticed that very quickly we were all able to provide virtual care in an extraordinarily rapid fashion. And I almost wish we had slides today, but it's okay that we don't. But if you see the numbers, you see, telemedicine looking like this, and then all of a sudden really doing this. And we had almost 100% telemedicine uptake in a majority of the country's kind of practices where it was feasible. And when I say telemedicine, I mean, we were using telephone, which is really a version of connecting with our patients, as well as video, as well as people who are branching out into really using remote patient monitoring or using wearables or digital health. Now, as we see people coming back into the office, as we see things opening up, there's a variety of things happening. One is there are certain groups who are maintaining that level. So here at Mass General and Cardiology, we still have an average about 70% virtual care uptake. Although my colleagues, because I do this kind of throughout the country with the American College of Cardiology, there are some practices that have gone down to almost no telemedicine or telephone or video contact. And what we find is it's all based in infrastructure. Those places that either had an infrastructure and grew it, or were able to build that, and I don't just mean infrastructure like broadband into urban and rural communities, but even just within the actual practice of delivering healthcare, those who established something that could last as a good infrastructure were able to continue. Those who didn't really just kind of fell back down upon this is the way we used to do it, and we don't have a model for doing it differently, and we weren't able to build it during that time. So I think it saved a lot of people because we were able to see a lot more patients. I will tell you there are a lot of patients who still didn't make it in. And a lot of patients who are so scared of healthcare. So if there is anyone listening who is still scared of healthcare, as you hear about variants and other things, we are a safe place to come. If your doctor wants you to come in, if your nurse wants you to come in, if your dentist says it's time to come in, listen to them, have that discussion, and don't be scared. But I think things are changing, and we're headed back in a different direction. And without infrastructure, you see that it's harder to keep that up.
Has that been your impression as well, Dr. Ajayi? And I'm also wondering if you could weigh in on what you're seeing across the various specialties. Are there certain specialties where it makes a lot more sense to keep seeing patients virtually, and others where, you know, you're likely to see this kind of resuming of the status quo?
Absolutely. So just to contextualize a little bit sort of where my comments will come from and the perspective I'm bringing on this, I'm at Cityblock Health, and we're a provider specifically focused on marginalized populations. The vast majority of the members that we serve receive Medicaid or are dually eligible for Medicare and Medicaid and have significant physical health, behavioral health, and social needs. And so this is a population that requires really high touch, high engagement in order to achieve improved health outcomes. And we're structured within value-based agreements and relationships, which means that we are incentivized to meet folks where they are, to manage across a population of individuals, and to help drive outcomes. And that's relevant to this for a couple of reasons. First, in the sort of pre-pandemic era, telemedicine uptake in these populations was incredibly low. And so Dr. Bhatt talked about, you know, at baseline, on average, telemedicine uptake before the pandemic was low. It is even lower in these populations. And there's two kind of core reasons. One is that has been historically belief that these populations can't engage in healthcare using tech. And so people haven't built tech for these populations. If you look at the sort of the proliferation of tech-enabled apps for health, for coaching, they're not really geared towards low-income folks with low health literacy, folks who don't have access to technology tools. They're geared towards mainly the commercially insured population. And so there was just a dearth of focus and investment in those populations. And the second was we had not really thought about some of the real structural barriers to accessing care in this way. So while we know that smartphone prevalence is relatively high across the income spectrum, data availability is not. It's expensive for many people. Many folks don't have private spaces to have telehealth visits. And then there's tech literacy as a real major barrier. And we, you know, as a tech-enabled provider of care for marginalized populations in the pre-COVID era, had already started to work on overcoming some of these barriers. It's really important to us to have telemedicine as a tool in our toolkit to enable us to meet members where they are 24/7 across modalities. And so we were already very heavily using, in particular, SMS technology. So simple stuff. It's exactly what people are already using. It's a native app. We weren't trying to, you know, push people to the app store to download another app and figure out and eat up all their data. Even though we do have an app focused for our members as well, we were really thinking about multimodal engagement. As COVID hit, we ramped that up dramatically, like everyone else did. We saw a 250% increase in text messaging and telephonic communication across our members, a 10x increase in video visiting, and we put in place a number of innovations to bridge that technical divide, including actually going to people's homes, setting them up with tablets, facilitating video visiting. So we have EMTs and paramedics in our members' homes who help them participate in a video visit with physicians who are virtual. We've been getting technology devices to people, so smartphones and tablets, really trying to understand what it looks like to bridge that gap. And what we're seeing as folks return to sort of in-person care is a couple things. One is, you know, I think we are really trying to push ourselves and the community writ large to not go back to business as usual entirely, because it kind of didn't meet people's needs at baseline. And I think what COVID has taught us is that if we have a healthcare delivery system that is predicated on people, you know, taking time off work, finding childcare, leaving their homes, going on transportation, sitting in a waiting room full of other sick people in order to get 10 minutes of an in-person visit, and that is the only modality for care, we're failing to meet people's needs. And not to mention when we reimburse that in a fee-for-service structure that undermines our providers' ability to actually show up for folks, we don't need to go back there. And so what we're trying to really leverage and to show is that with value-based payment models and some of the payment flexibilities that were created during COVID, we can use telehealth as a modality, permanent modality, to extend access to care, and think of it as a health equity tool. Think of it as a way to get more care to more people who need it, to overcome some of the barriers that folks have to go through that convoluted cycle in order to get healthcare. And so for us, that's been really focused focusing in on places where we know that telehealth can provide really great access and outcomes, behavioral health being one, low acuity follow-ups being another. So there's no reason for you to come back to see your doctor in the office to go over lab results. You could just talk to them on the phone. And then urgent care and emergent care. It's way more efficient and certainly more enjoyable as an experience for patients to have someone come to their home when they're in crisis than to ask them to go to a provider. And if we can facilitate that virtually, so much the better. We are seeing, however, the broader ecosystem is rushing to bring people back into the office. And we're seeing that across the board, especially in specialty care, because our reimbursement model really incentivizes that. But I don't think that has to be the case. And I really hope that we as a collective leverage the lessons from this experience and really, really use them to provide equitable care using telemedicine as one of the modalities.
Thank you so much. There's a lot to dig into, and I want to come back to that. I especially love what you said about telemedicine being a tool in the toolkit, because I think sometimes we can fixate on telemedicine as a solution versus just one kind of piece of the overall kind of puzzle that we need to provide to patients. So moving to you, Harsh, your company is in the heart disease space. And so you've probably seen some really interesting things during this pandemic with your patient population. As I understand it, you were not one of the companies that kind of pivoted into virtual because you've kind of long been a virtual company. So talk about some of the opportunities, but also the limitations. Like, where do you kind of draw the line and say, actually, you know what, this patient needs to come in? And what's been your experience of that so far?
Yeah, thanks, Chrissy, and thank you for the opportunity, everyone. At Moving Analytics, we provide virtual rehab services for a patient after they've had an acute event, like a heart attack or heart surgery, right? So prior to the pandemic, as it stood, participation in post-acute rehab was already very low. It was less than 16% nationally, and even fewer people completed it. At that point in time, our proposal was that we could significantly increase access to rehab by offering it to patients who the primary reasons they don't come in are basically distance, time to travel, taking time off from work, and cost and co-pays to some extent as well. So we said, let's take that experience that's in person and develop an evidence-based therapy that can be done at home and leverage telehealth to deliver it. Prior to the pandemic, the kind of responses we used to get were, patients aren't going to do this. These are older patients. They're not as familiar with technology. And on the clinician side too, I think we got a lot of pushback saying, now we got to learn one more app. We got to learn how to use this dashboard and so on and so forth, right? So what happened with COVID was, because at least at that point in time, cardiovascular patients are at higher risk for complications from COVID-related COVID infections. Essentially, the whole national cardiac rehab infrastructure collapsed. Basically, every rehab facility was shut down for a period of time, or was operating at reduced capacity. And so there was a situation where you have all these people who have acute events, but they have nowhere to go. And so from 16%, it went to like 1% or 2% nationally, right? So, and there was a period, basically, I would say from April to June, where everyone was forced to deliver rehab virtually. And people liked it really well. And I think there were 2 points that I think were key in that. So one was people found out that technology familiarity is not as much of an issue as they thought it was. Older adults already use a lot of smartphone apps. The age is really not a correlate for technology familiarity. Income level probably is a strong correlate for that. The second part was that essentially rather than relying on video calls, the telephone actually emerged as a major workhorse of delivery. Everybody has a landline or a telephone, mobile line. You can still have great, rich conversations, and you could use that as the linchpin for delivering rehab and managing a patient's journey post-discharge. So I think that was like a very useful insight that we got. And we continue to rely on telephone actually as our first choice for delivering rehab, and then offering telehealth or video visits as an additional enhancement if people want them as well. And so as that pandemic evolved and things started getting more and more relaxed, and people were able to come back, I think there's been that sort of a refreshing attitude where we say, let's not think about whether this is virtual or home. Let's worry about what is the patient's choice, right? So what do they prefer? If they prefer center-based because they would like that face-to-face attention, let's make it available to them. But let's also educate the patient about their options. So let's let them know that, hey, if for some reason you can go to center-based rehab, but if for some reason you can't continue your sessions because you have to get back to work or because you have to drive long distances, we can continue this process of rehabilitation in a home-based setting, and we have the tools to help you achieve that, and we can help you do this as well. And the other way too. So if, for example, someone does home and they're like, you know what, I don't really like this experience as much. It's very impersonal. I want to see more people. Then yes, you can go all the way to a center-based setting. But the point is that it's now you have virtual as one of many tools in your toolkit, and you can deliver it, and you can therefore reach a whole set of patients who you would not be otherwise able to reach. So it's not a panacea, but it's definitely like a expansion of what's available. And I think there's another aspect to the student cardiovascular, which is if you can triage patients based on their risk level and their preference, you can improve the efficiency of the system overall. And so I think what we were able to show is, interestingly, with our protocols, that in the people who do home, 40% of them are women, whereas in center-based, it's less than 10%. So we were actually getting patients who are not joining otherwise. In Veterans Affairs, 50% of our patients were African American, whereas in center-based rehab, it was less than 10%. And so that, again, it goes back to that expanding the size of the pie rather than just taking more of the same pie, right? So, but then you're giving people more options, but you're not making it compulsory. You're saying this is available for you now that wasn't available before. That's been our experience, I'd say. Yeah.
I love the idea of giving patients what they prefer. And I was sort of reminded as you were sharing some of your insights, Harsh, about a neighbor of mine who, prior to the pandemic, I saw him kind of walk out of his house. He's in his early 80s. He was wearing a suit, and I said, "Well, you look dressed up. Where are you going?" And he said, "To the doctor." And this neighbor of mine, he's relatively lonely. I mean, we spent time with him in our community, but he's somebody that really looks forward to going to the doctor's office. And I think there are a lot of patients out there that feel that way, that going to the doctor isn't a pain or a hassle, it's an event. And so, given the sort of topic here that we're discussing today, I wanted to touch on that a little bit more and just see what do we think, potentially is being lost as we kind of roll out more of these virtual tools? And, is there a way to kind of ensure that, as we move to more of these sort of hybrid models, that we still have these relationships that are so important to these patients? So do any of the physicians want to jump in here?
Yeah, I'll jump in. So I think this is kind of the crux of the issue. It's not an either or, it's blended medicine. And so you say hybrid and we use the word blended. I think we mean the same thing, which is for any given patient, even your neighbor, there is a situation in which it is better or more convenient for them to be home. There's a situation in which they're going to want to come in. And for their provider who's caring for them, there are situations for which we really want to lay hands on someone, which happens a lot in cardiology, and others in which we're okay reviewing your most recent MRI with you. In fact, it's better for us to do it over a video when your daughter is there with you and we're explaining to both of you what we see, rather than sending you a MyChart message or calling you and having the nurse say, "Hey, your MRI looks great," which doesn't really do any patient education or empowerment. So I think for almost every situation, what we need to learn is how to be agile in healthcare delivery. That's the change. The change is not one of, do we use digital health or telemedicine? I think that is here to stay. I think Toyin is right. Digital health, telemedicine are here to stay. It's in your practice. What are the right times? Who are the right providers? You will not get everybody to get on board. But as you had asked earlier, Chrissy, in terms of which subspecialty, every subspecialty. there is a case in every subspecialty where there can be the use of telemedicine. It's interesting, if you just look at the news today, there was an article about how Harvard Pilgrim and another health group in Michigan, Priority Health, I think, are both using telehealth first mechanisms as one of their products now. So private insurance companies saying, we're going to use a product that is telehealth first. Feel free to connect with any one of your physicians, no matter what or nurses, no matter what the subspecialty may be, get a sense of what's going on and then figure out what comes next. And so that's, one potential way to use it. But I think if we remember that there's a combination there, it's important. I will tell you one thing though, and Toyin was right, value-based care makes a huge difference. So if we look at our population, not the ACO population at Mass General, but if we just look at all comers in a kind of RVU generating fee-for-service model, we really did have individuals of Black race, of Hispanic ethnicity, age over 85, and those who had heart failure as individuals who were not getting the same kind of telemedicine engagement that the rest of our population was. And we just published on that last week. But the part that was one step further is we had this concept, what if we push through? What if we take the providers in the highest quartile of using telemedicine, those who are most comfortable, right? Can't we push even a little further with those individuals? And it turns out, no, we still weren't getting those same populations for the reasons that Toyin talked about. And so now we're using a digital navigator program. And similarly, we have blood pressure cuffs being donated and tablets being donated because you need that kind of intensive work to be able to get into certain communities. That's not easy for every single practice to do. That is not easy for every single practice to do. What is easier is getting on the phone. However, there's going to be a challenge. We were on the phone with the Government Accountability Office. I took a meeting with them, because they will be advising Congress on, what to do next. And I'll tell you, the telephone part of that conversation was the hardest for us to convince people that you can legislate, you can be accountable, you can demonstrate the benefits and the effects. And so I think that's where a lot of our work and our research, like Harsh and Toyin are doing, are necessary. I think that's part of the equation that we still risk losing.
If I could just add to that, I think that we should, when we talk about sort of meeting people where they are and meeting their needs, using as many tools as we need to in the toolkit, I think your neighbor's story is such a great one, right? And so in days of yore, in a traditional fee-for-service environment, in a traditional care delivery environment, we were solving for loneliness and social isolation in his life through a doctor's visit. And a doctor's visit that required him to go to the office and receive care in a modality that may actually not have been optimized for his needs, because we know, particularly in geriatrics, we know that when your neighbor puts on his suit and goes out to see the doctor and sits in front of the doctor in the office and says, yeah, everything's fine, things are great, I feel wonderful, we have no visibility into the fact that maybe his house is cluttered and he's at risk for falling, or maybe actually he's disheveled most days of the week because he has nobody around to support him, or maybe there's no food in his fridge because he's too proud to ask for help with cooking. And so actually, like, we may not be doing him any favors either. What he needs is a longitudinal relationship that's anchored in meeting him where he is, and that's including in his home, and that solves for not only his physical needs, but also his mental health and social needs. And so when you think about how we could deploy technology in exactly the same scenario, what would it look like if he had a community health worker, or in our model at Cityblock, a community health partner in his home, doing a full psychosocial evaluation, who then facilitated a video visit with his physician, so that when the physician says, how are things going with your meds, we can pull them out and actually look at them together and look at his medicine cabinet, open his fridge and say, you know what, I don't know if you should be on such a high dose of insulin when there's not enough food in here for you to take with it 3 times a day. That also allows us to say, what does it look like to create social supports for frail seniors in a world in which technology and access to technology as a tool for social engagement is critical? How do we help him at 80 get online? Because that may be a really wonderful and scalable and sustainable portal for him to remain connected with society. Is this starting to become part of a sort of almost a basic set of requirements for thriving in the digital age? And can we support him in that? And then, finally starting to think about over time, where we want to push the healthcare system to make investments, to close gaps for folks, to innovate even further with this user in mind. And as we see, telehealth companies that have been doing largely episodic care. So, we have a very well-established model for, a doctor on demand like service, and there's a number of really successful and wonderful companies in this space. Let's not forget that the longitudinal relationship is really important as well. And so, as a primary care physician, when I think about virtual care, I think about it as supportive and reinforcing of those longitudinal trusted relationships that require a named human to interact with a named human. And that's logistically and operationally much more difficult to coordinate and to scale, because it means that when my patient wants to talk to their care team, it's the same people who've been caring for him, who he has a trusted relationship with. It's not pick a doc, any doc will do to meet these needs. That's a really important design principle as we start to really scale out our ability to meet folks' needs in the primary care space in particular.
So from our perspective, I think what we've realized is technology is the channel. It's not the solution, right? So, and this is also my favorite pet peeve is when you see studies showing, oh, like this app didn't improve outcomes. Yeah, the app is not going to improve outcomes. At the end of the day, going to be physicians and care teams that are going to be delivering outcomes, and the technology is just how you deliver it. We've realized that the single biggest factor that contributes to good outcomes is the strength of the relationship between the patient and the coach who's delivering the program, who's a nurse or exercise physiologist. And Toyin and Ami raised this point earlier, which is like that longitudinal relationship where you realize that you have a trusted resource or a team of trusted resources available for you to answer questions is super, super important. Someone who has a heart attack, they had a life-changing event. Literally they were minutes away from death. They're scared. They don't know what to do. They don't know what's the next step. They don't even know if they can get up and go to the fridge and pick up food and come back because they're scared. They're worried that may cause another heart attack. And taking them from that position to saying like, hey, what, this is not the beginning, it's not the end, it's the beginning of hopefully a great long life for you. And just saying that itself has been a revelation for patients, because people think that, oh, this is it for me. Like I have a year to go and then I'm gone, but just saying, you can live another 25, 30 years. Let's work together, right? And then working with the patient from the lens of empathy to really understand what is their life like, what is their friends and family. They have kids, they have pets. Do they live in alone in the mountains, or do they live in a busy street? Like where do they live? Do they live in a dangerous neighborhood? Do they live in the tundra? Like knowing all of that, and then creating a customized sort of roadmap for them that is built in consultation with them, like they are the people who own that roadmap for their lives, has been like super important. Knowing for a patient, what we found is like when the care manager or the coach basically comes to you and says, I want you to do what you think makes the most sense. If you don't think exercise is important for you, we're not going to do that. Just saying that helps the patient get control over their lives. And then you can use that as a launch point to build more healthy relationship, healthy habits and everything going forward. So I think end of the day, the where technology has been helpful is in promoting transparency through that process and in getting and increasing access, right? But it is still about that patient-provider relationship. And to the points raised earlier, it's about having a team of resources that are guiding you through your journey, and it's for the rest of your life. It's not something that's episodic as well. So that's just been our experience in that space.
Absolutely, and I totally share that pet peeve with you, Harsh. So thanks for bringing that up. So I wanted to touch on this issue of trust, because I think, in this post-COVID world, we're going to be reflecting a lot on lessons that we learned during the pandemic. And I think a big one was there's so many patient populations out there that feel like the system doesn't work for them, that physicians won't listen to them, and that, I think there was many conversations about the inequities during this pandemic in terms of, who got kind of more severe their COVID. And we saw that, writ large, but these inequities have existed for decades before this. So I think it just further exposed what was already there and what was already broken about the system. So how do we begin to think through rebuilding this trust? And does technology take away from it? Will there be certain patient groups that say, why am I being given, this SMS solution? Is this a lower standard of care and I'm getting this because I'm less important to this physician? And how do we kind of work through some of these problems in this kind of world as we emerge from COVID and move forward?
So I'm going to ask Toyin to go first because I would love to hear her thoughts. And then I'd like to share some thoughts centering on maternal mortality to kind of use as an example.
Sure, I'm happy to. I mean, I think the first thing is around framing, right? And so, we truly have framed and contemplated virtual care as a tool to expand access, to ensure that we meet our members, and we particularly demonstrate that it's possible to engage marginalized, higher risk populations with the level of frequency and the level of respect and dignity and autonomy that we afford to other populations. And so there's a framing issue and question here. That's thing number one. Secondly, I think it's then starting to ask, well, what does it take? An equity framework says we're not making equally freely available the same level of care to everyone and then sort of standing back and waiting to see who can access and letting the chips fall where they may. It says actually we're investing differentially in ensuring that our innovations and our interventions meet the populations that need it the most in the ways that are meaningfully going to drive outcomes for them. And so for us, it means, doing the work we've described around helping to close that digital divide with folks, sitting side by side with people to help them access technology, if that's their preferred modality for care. It includes making sure that we're accountable for outcomes and not simply for delivery modalities. So, my answer to the very specific sort of, am I getting the SMS-based care because I am less worthy or less important? The answer is we're doing whatever we can, and we're using SMS plus other tools to get you the outcomes that are optimal for you. And it becomes, again, yet another tool and not another modality. I do have concerns for sure when we look at two things in the sort of COVID era. When you look first at the uptake of telehealth across the board, across the populations, what we don't see really is a disaggregation of like, what does telehealth mean in this context? And so for lower income populations, and we see this and hear this a lot, being served particularly by community health centers and federally qualified health centers that don't have the resources, maybe didn't have the infrastructure, didn't have the flexibility to pivot as fast to video visiting, that really meant phone care. And that's fine for some folks, but it's actually not fine for everyone. We haven't tested and identified the extent to which specific modalities are able to drive outcomes. And we know that there's been real disparities in terms of level of access to the type of quality of care in this environment by race, ethnicity, by income, by geography. And so I think we need to study this more and actually honestly get a little bit more opinionated about where telephone care may work and where actually it's not sufficient. I think value-based care modalities, and I keep going back to this, help a lot because it really anchors us to outcomes as opposed to simply what we deliver. It really translates to, does it work? And if it works, then great, let's go. And if it doesn't work, then absolutely we should do something differently for the populations that we seek to serve. And so I think we have an opportunity to, again, through framing, start to ask, what will it take for telemedicine as a tool to be able to, and telehealth as a tool to be able to drive outcomes, to enhance access for populations that didn't have it before. Let's measure it, let's be rigorous about it, but let's not sort of rest on the notion that this as a sort of blanket solution may lift all boats, because I don't believe that to be the case, and certainly our experience in healthcare has never proven that to be true.
Thank you. And before we jump in with the discussion of maternal health outcomes, I just wanted to see if anybody tuning in had questions, because in the last, say, 10 minutes, we'll move to Q&A. And with that, I will leave it to you, Dr. Bhatt.
Sure. So yeah, please bring your questions. We would love to chat about them. It's interesting because when we talk about access, I hear from both of my co-speakers, actually two things that come before access. One is patient empowerment, which I think is what the concept of telemedicine does. And the other is the concept of continuous care, which is really what we've not ever offered as a model. And now if you think about what good quality, safe care looks like, it does not look like episodic care. The idea that episodic care is higher and safer quality is absolutely wrong. And all people would kind of agree with that. So with that in mind, as a cardiologist, what are the things that we really think about? So hypertension is a huge one for us, right? And our last Surgeon General had kind of emphasized this at the end of COVID, which is we need to attack hypertension. I specifically work with Go Red for Women, and I do cardiovascular disease and maternal health. And so maternal mortality higher in the US than any other developed country. And we as cardiologists carry a large burden of that in terms of hypertension and pregnancy. And we know that good prenatal care leads to better outcomes. But bringing those women in, or even offering them a video visit, I'll tell you, I've had patients, multiple now, who've said, I need that iPad and that data stream for the kids who are on Zoom school during COVID. Like we have one resource and we have 7 of us here. And so I just need you to tell me, here's my blood pressure. What do I do now? Here's my blood pressure. That's where the SMS texting was actually a way for us to be respectful of her needs. And so again and again, patients say it is a sign of respect when you offer us these different modalities of telehealth and let us figure out what fits in our. And so I think that's the lens that we don't use. We say, well, you got less than they did because they got video. Well, sometimes, yes, you need to see the room, see the meds. Other times, no, you need to fit their life to get them the kind of care that they need, the continuous care in pregnancy. And there's trials. And we have data that shows that SMS texting actually decreases the rates of preeclampsia, which is important because our Black women colleagues, even in the suburbs of Boston here, even with very high education, still have a significantly higher risk of maternal mortality. So that is crossing SES, that is crossing educational level. And so there's something that we need to do. And it turns out that whatever form that person needs, that's what you need to give them. And that's a sign of respect. And I think that's the frame shift that we don't have. I think the other part is a little implicit bias. I assumed you're a Norman Rockwell type physician, right? I hold your hand in the office. I'm one of those. Patients want to come to me and hold my hand. And I had a patient just a month ago who said, no, doctor, I don't want to come in. And I was like, but you need your 3rd open heart surgery. You're only 39. Like in my mind, I was like, I need to tell you this. Finally, he said, Dr. Bhatt, I know I don't feel well. I know you have something to tell me. I need to be at home with my kids and my family when I hear this news, if I'm going to go under the knife again. That was a statement I got. I made an assumption about what the doctor-patient relationship means to him. And in fact, he needed the exact opposite. He needed to be nowhere near me. He needed to be home with his family to do this. And so I think we carry a lot of implicit bias, both culturally, but just in general about what it means in a doctor-patient relationship. And a lot of that is paternalistic. And we need to move that to that partnership. So I would say access is important, but patient empowerment and respect for our patients, and then this continuous care, those are the 2 things that drive access. And I think that's where we need to kind of emphasize. I see some questions coming in though.
Yeah, I might ask one of these. We sort of touched on it with the specialties question, but we did get another kind of another person asking, what makes most sense for telemedicine when it comes to these different kind of patient populations or even medical specialties. And you see, a lot of it is kind of what makes most sense for that particular specialty, but it's also which physicians are most likely to adopt telemedicine. And you see this there was a great chart from Doximity that came out kind of recently. I think they do it every year, of just which, they would poll or survey their doctors by specialty and say, how open are you to virtual care? And of course you had kind of PCPs at the top, very open, and then you mentioned maternal health, obstetricians are always kind of typically kind of around the bottom, just because of how much in-person care is typically required for that specialty. Although I think you make some really good points about the virtual component to this, and it's very much top of mind for me because I just had a baby. So let's dig into that. Where does it make sense? Where doesn't it make sense? And then, is it genuinely the case that it could be, a blended or hybrid approach for every specialty?
So in determining acute from non-acute care, it's actually helpful to have a televisit. It's helpful for people who can't get in easily, for you to just look. And I will tell you, the physicians may hesitate and say, well, can I really? Yes, you can. You are talented. You can look at a person. You can tell sick from not sick. We always say 90% is the history, right? And then just the gestalt by looking at someone, you get a real sense of acute from non-acute. So I think there is a role for triage that people can try. I'll go back to what you said in the beginning, though. So review, let me give the list. Triage, the ability to review data. Data review doesn't need to happen in person. It can happen brilliantly over this. If you have video, if you don't and you have phone and you want to show something a little different. I think those are two areas. There's a lot of pre and post-op follow-up that's now done, partly virtual, and then bring people in if you're not sure. So pre and post-op has really grown during COVID because of a fear of catching COVID, right? So that started back in July. And I think anything you can think of, blood pressure management, brilliant at home. Doesn't even involve the phone or the video, just involves the Bluetooth blood pressure cuff uploading, right, at the local community center. So there's a lot of different mechanisms. I'll go back to the patient provider, though. In every field that we see in doximity, which on the low end of we don't really adopt telemedicine, there are those who believe in changeability. There are those physicians and nurses who are ready to change. We're not just talking telemedicine. The next 10 years entail real digital health, remote patient management, other things. Those who are willing to adapt to change and speak up for what is right for patient care, those are the people that are going to push those fields, and not the entire field will follow telemedicine. But I think in every field, you're going to have a group of people that's almost a subspecialty that will grow. And then we will teach our med students and our residents about how to be very agile with system change. As physicians, we're very agile with clinical change. One day you need a surgery, but you may need palliative care. I can do that in one admission for you. I don't always do it in that direction, but I can do that for you. But in terms of systems change, we're not built to be agile for systems change. So I think those are the people, and that's what we need to teach people. And that's how we're going to achieve blended care.
Yeah, I think I would just add to that. I think the answer is honestly, we don't know yet. I think for, a large part of this goes back to sort of my earlier point. This is a tool in the toolkit. It's not going to be a solution for everyone that we can apply like peanut butter across the ecosystem. Different folks have different needs, they have different preferences, and really thinking about telehealth as an ability to enhance our ability to meet people where they are, meet their needs. People have to opt in. Both the providers have to opt in and the patients have to opt in. And so providing that as truly as a tool, as an option for folks, I think is really critical. Certainly, I think primary care, we're seeing we can do a ton virtually. Chronic disease management, absolutely. Behavioral health, I think, is a really, really important opportunity. And, they've really taken it and run with it. And I think we'll see more and more there. But I would say that, 10 years from now, if we ride this opportunity and the tailwinds that were created through the sort of force towards telehealth, and really use it as an opportunity to push in and to learn how to do this well, I think we will find that we're using this in use cases we hadn't envisioned possible in the past. And so this is a real opportunity for us. And I think that you'll see the early adopters pull forward. You'll see the rest of the field follow. But my hope is that we can empower patients as consumers to tell us what they need, to tell us when and where they need us to show up differently in order to actually meet their needs.
So I'm going to jump in here with a question that has been raised a couple times, and I love that this crew is so into data and informatics, because we've been getting questions about PHRs, which makes a ton of sense, kind of given the recent rules. And sorry for my baby in the background, but I wondered if anyone could weigh in here on the PHR question. How much do you think in the future we will be kind of sharing health information with patients? Is the physicians comfortable with even sharing your notes? Are you a fan of open notes? Do you see patients using PHRs? I certainly have access to my chart, but I just find it to be a bit of a pain, given that you have to I go to health systems that don't use Epic. I go to some that use Cerner, and so just trying to kind of get all that information together is a challenge. I'm curious for your thoughts on that as well, Harsh, with what you were seeing with your patients. But yeah, let's. I think we should kind of wrap up with a question on that, because it seems to be one that our audience is very interested in.
I can tell you that the biggest, I would say, headache in our company operations is getting the initial medical history of a patient. And it's crazy how, you talk all about, all this APIs and Farr and all that stuff. When it comes to a final cardiologist office, and I know there are cardiologists in this call, so I'm gonna temper my language. End of the day, the only way we could get a record is calling someone between 8 a.m. and 11 a.m. And have them, and they request that we make a request in fax format. So we had to find a HIPAA compliant fax machine to request medical information and then receive that information back. And what we were basically asking was their basic clinical vitals, lab results, and so on. And it also, their fax machine was broken, so it took us about 3 days to figure that out. And then after that, end of the day, I think what it resulted in is us FedExing like a request in a written format to get that for that one patient, right? So you won't find a bigger fan for having data interoperability than me. I think from our perspective, in terms of product design, we make it super easy for the patient to basically print out digital format. If you want, we can even give you like an Epic packet that you can send to your cardiologist, so that it's super easy for them to own their data. We actually strongly believe that they also have to see what the coaches write about them in their note summary. They're empowered to do it. They can see every minute change that was made to their treatment plan, and they can share it with whoever they want. It's just a philosophy that we have, which I think, and we've not gotten in trouble about it yet. In fact, patients really appreciate it. I think on the physician side, I think there's we should promote the ability to access personal health records. We've had to have like the patient's kids call the patient and threaten the cardiologist office to get the records. Otherwise, they're not going to continue things, care with this cardiologist and so on. We've had cardiologists saying, I don't want to give you this record because I'm retiring next week and I don't want to deal with this anymore. So, what I think is important here is less about the cardiologist or the physician, but actually working with the staff and working with their workflows, because at the end of the day, they are the folks who are super connected to the day-to-day operations of the clinic, right? So, and training and embedding yourself into the workflow of that team, who tend to be RNs, PAs, and so on, I think is super important to be able to get that information, barring all the technological improvements that need to happen. So, but that can be a whole different webinar, but we'll talk about that later. Yeah.
So I think this is a big topic.
I think based on just everything that Harsh just said, that is why a personalized health record is important, right? For his sake, for the sake of our office staff, we're trying to talk to patients, et cetera. But I will say, to combine two of the questions that I see out there. So I think it's really important for interoperability. I think we already see that, so all my patients can see all my notes now. We have open notes, like I'm an open book now. And actually, the majority of patients don't have a lot of issues. Once in a while, there's something or the other. And in fact, sometimes I write notes on virtual visits with them just looking at my screen as I'm typing, and they love it. They're part of the process. By the way, my note's done before the end of the visit. So I think that we're going to get along with. But I will say, to kind of drill in the other thing, remote patient monitoring that integrates with my system. So when I'm seeing them, I'm seeing their remote monitoring. And then yes, to the data analytics. Precision data analytics are going to be essential moving forward. We have to go back, Christine, and address what you said, which is the trust portion from the providers and the patients. And we have to start addressing that now in terms of the fact that, yes, we're going to have predictive analytics, but that doesn't mean a computer is going to decide your next medication. That means it's going to make it easier for doctors like us to be able to have the important information to make the clinically high-level decisions for you. And so I think moving forward, yes, interoperability, yes, PHR is essential, yes, data analytics and precision data for our patients where we are given the baseline upon which we can then make a clinical judgment. I think that is the future, but we all have a lot of work to do in terms of trust to get everybody there.
I do want to jump to Dr. Ajayi on this, but quick question for you before we move on. when you are sharing your notes with your patient, are you amending the language that you use? Are you, the medical jargon, for instance, that a patient may not be able to understand? Or what if you want to write in your notes that a patient is obese or, has particular health problems that maybe they themselves don't necessarily want to see right there in the notes? How do you think through that? And then we'll jump to Dr. Ajayi.
This is where Dr. Ajayi is right. The longitudinal relationship makes a big difference. I'm going to have to put the word obese here because technically your weight comes over 30, but I know how hard you've been working on that, right? And you just have to be, and there's some times where you don't want to show the note because you know that somebody else just discussed their mental illness and dual diagnosis and they're not ready to talk to you about it yet, even though you know from the record it happened. And so for that patient last week, I didn't do that. And so I think you're right. The longitudinal relationship makes the ability to deliver this kind of care much better. I really am also a fan of, I know that the kind of doc of the day thing exists, but this is where my judgment is used in our relationship to know where we are and to move that relationship along. I may need them to see the word obese and the fact that I have to put it in their record because they're there to help motivate them to get where they need to get.
Yeah, I couldn't agree more. I mean, I think this is a continuous bugbear, I think, for providers, because it actually feels very exposing of the power dynamic that's inherent between physicians and other healthcare practitioners and patients. We get to say stuff about people that we believe they don't have visibility into, and it is pervaded. I mean, I think your example, Chrissy, is one, but there's language scattered across medical records that is just unkind, that is laced with bias, that is hurtful, and that is unnecessary to inform clinical judgment. And we do that because we're able to. And I actually think, breaking apart and recognizing that increasingly we lost the opportunity, I think, a long time ago, unfortunately. And I'm less optimistic that we will achieve interoperability. I think there's a moment, I think, from a regulatory and legislative perspective where we could have sort of made that happen early, and that moment has passed. And so, I think that this is going to require a real movement on the part of patients, consumers, the general public, to say, actually, this is our data. This is my body. These are my images. This is my health. And let's really use this as a way to empower and to break apart some of the power hierarchies. And so it means that the clinicians will be uncomfortable. It means you pause for a second before you write that thing down in the chart, because you know that the patient can read it and they're going to ask you what it means. And it means that not that you're sort of changing your language, not that you're not using anatomical terms, not that you're not sort of stating the truth about their diagnosis and prognosis, but you must be prepared to describe it and explain it in English or whatever the person's spoken language is, such that they understand. And that is really empowering of patients, as it should be. And it will feel complicated and tricky for us in the healthcare system because we built systems and tools and nomenclature and norms around the opposite of that. But I really do believe that this is foundational to building trust and to creating even the semblance of what we could describe as a functioning market in healthcare. Requires that information asymmetry is eliminated wherever possible, where we really give people access to their data and their information and the ability to port that around and to use that to inform their own choices.
Well, with that, we are at time. So I just wanted to thank the panelists for being here. This is an amazing discussion. We got into topics that I think are rarely discussed in digital health and need to be talked about so much more. So I just really appreciate the candor from the three of you, and thanks to MedCity News for having us, and for recruiting such a diverse panel as well. I'm typically the only female on these panels, so this has been refreshing for me, just on a personal level. So I hope we can do this again, and thanks to all the questions as well, such thoughtful questions from the audience. I wish we'd had time for more, but we'll do this again. So thank you again.
Thank you so much, Chrissy. Thank you so much, Dr. Ajayi, Dr. Bhatt, and Harsh. It truly was a very substantive discussion, and especially wanted to thank Chrissy, because she has a 2-month-old baby boy, and I remember myself back in the day, I would not have been ready to do a substantive discussion on the future of digital health and technology 2 months into being a first-time mom. So a big thank you to you, Chrissy. I wanted to mention a few housekeeping items. I know I was excited to have the chance to moderate a session with leaders at Microsoft and Google. It was supposed to be at 2 Eastern, however, due to unavoidable circumstances, the speakers have requested that that discussion be postponed. So please stay tuned. We'll figure something out on our end, and hopefully we'll have this discussion soon. The next thing to remember is at 4 Eastern today, we will have our pitch contest where we highlight 5 or 6, I believe, 6 health IT startups. And we have some excellent VC judges, active investors who will play the role of judge. So again, thanks to the panel, and I hope to see you back again at 4 Eastern. Bye-bye.